time. Hello, welcome everybody. I'm not usually a nervous person, but for some reason I'm a little anxious today. So I apologize. So thank you for all of you for coming today. This is something that is near and dear to all of our hearts. Hospice, and the title of our little program here is Hospice is about living until the last goodbye. So we are all hospice staff. My name is Alicia Krehbiel. I'm the clinical supervisor for the hospice house as well as our home hospice program. And I'm going to let the panel introduce themselves, and then we will come back and start our program. Dr. Otteman, you want to start?
Sure, happy to. Larry Otteman. In the Oncology department, I've been involved in the hospice program at Greeley since 1985.
Hi, I'm Shana Kilstrom, and I do most of the admissions and referrals, and I've been with hospice for the last 10 years.
Hi, I'm Teske Vance. I'm the bereavement coordinator for our hospice program, and I've been here since June.
And I'm Bohlen. I'm the hospice manager, and I've been here 3 years.
I'm Gardner. I am a hospice volunteer, and I've been here since 2000.
Okay, here we go. So our objectives for the day are to identify common misconceptions about hospice care, describe the services provided by hospice, and explain the benefits for the patient, family, care providers of having hospice care, whether that's in the home or the hospice house. And then lastly, identify how to make a referral to us or a request for an informational meeting for our patients' families. My clicker's not working, or I'm just clicking it wrong. Okay, so what is hospice? It is a comprehensive, coordinated program that offers compassionate care for end of life. So there's many criteria for hospice end of life care depending on the diagnosis. So there's different criteria for different diagnoses. And Shawna is the best one at assessing those things with the help of the physician and other providers. So the goal is to enhance the quality of care in life by providing comfort, but to not do curative care, so palliative support. Pain symptom management are always our priority, always. I can't say that enough. That is what we focus on. Medical, spiritual, and emotional support are also provided. And we'll talk a little bit more about that, about the services that we offer and how each different service provides the support. And then anticipatory grief support and subsequent bereavement is provided to families and friends and whoever the caregivers are. And that's provided by our bereavement coordinator and volunteers. And that's for up to 13 months after the patient has died. So oftentimes and I'm going a little bit ahead of myself, but oftentimes, even if we have a patient for 2 days or a few hours, bereavement support goes on for months afterwards, and that is truly what that patient and family needs. The patient needs it because they know that somebody's going to be there for their family member afterwards. So next is Val.
Well, you stood up, so I'm going to stand up.
I know, it's just my nerves.
Well, I'm just as nervous as you are. No, not really. I'm talking about the benefits of hospice. And if a patient has a terminal or a serious illness, there's a good possibility that the healthcare provider would suggest hospice care. And often families are upset to hear this. They're thinking, you're giving up. Why are you giving up on my loved one? But what it really can mean is a shift of perspective from curing an illness to providing comfort and quality of life, like Alicia just said. We aren't curing the patient. We're there to help them get through the last days of their life. And when is the right time for hospice? You can see on the PowerPoint. The sooner the better. We need patients sooner. One common myth about hospice is that hospice is for the last days of life. And we'll be talking about the requirements later about, 6 months. And sometimes we have patients even longer than 6 months because they continue to decline. But the earlier the hospice is involved, the more it can help make the final months, weeks, days as comfortable and enjoyable as possible. And by choosing hospice sooner, patients and families can receive the full benefit of hospice in a number of different ways. So I have several benefits that the patient and the family receive. The greatest advantage, especially when choosing hospice sooner, is the time with their loved one is more pleasant and comfortable because the quality of life is enhanced. I remember when I first started working in hospice years ago, I remember our director saying, hospice is a gift. It's a gift for the patient and the family to have this team of professionals and non-professionals come in and share their hearts with these families, to educate them on the end of life and to elicit goals. What do you want to do before you die? You know, it is a gift. There is time to address and complete patient-family goals, like I just said. Number 2, we alleviate the patient's pain and symptoms. Alicia mentioned that. That's what we do the best. We get to the hospice patients and family get to know their hospice team and build a better rapport and a trusting relationship. It's hard to do that when you only have a patient for 24 hours. It's better if you can have them at least 2 weeks. Caring for the dying is a complex enterprise that must involve multiple professionals and non-professionals. And Shawna's going to be talking about all of us who belong to that team. We collaborate with other healthcare professionals to coordinate a treatment and a care plan. And patients and their families have access to this team that would address physical, mental, emotional, and spiritual needs by acknowledging their fears, their anxiety, their loneliness, and sometimes their isolation that occurs at end of life. In other words, the team prepares the families and their loved ones for what's to come. Another benefit for hospice patients is they receive medications, medical equipment, and medical supplies. That's all part of what they receive in the hospice benefit. They also are able to have several levels of care. Most of our patients are in the home setting, and that could include an assisted living. It could be a facility-based facility. And that level of care is called routine level of care. If a patient's symptoms get out of control, they can come into a hospice facility or a contracted hospice or hospital that we have to receive general inpatient level of care. And then we have the respite level of care, where if there's caregiver breakdown, the patient can come into the hospice facility or a contracted facility for 5 days so that caregiver can get the rest they need, go on vacation, or do what they need to do. Alicia already talked about the benefit of bereavement, so I'm not going to talk any more about that. It's interesting because there's evidence to support a higher quality of life in hospice patients compared with terminally ill patients in a hospice setting. And research also suggests that for certain diagnoses, for example, congestive heart failure, some of our patients will live 29 days longer than those patients that choose not to get hospice with the same diagnosis. Because we give such great care, don't we, guys? Say yes.
Yes.
Thank you. Okay. Family members are consistently more likely to report a favorable dying experience of their loved ones when hospice is chosen compared to hospitalization. Now you can see on the PowerPoint, Mary Greeley Hospice's average length of service is 29 days, and that's been our average for the last couple years. It's interesting because about half of our patients die within 14 days, and 30% of those patients die within 7 days. So that doesn't leave us very much time when they could have had that opportunity to be with hospice for 6 months or more. So hospice care is found to be the most beneficial when the patient receives care for a month or longer. I'm going to pass the mic to Mary Ann.
I hope you don't mind if I sit. I can't read my notes if I'm standing up. Okay. As I said, I've been a hospice volunteer since the year 2000. I went to a presentation of a church group that they had the hospice house manager come, and I thought, oh, big deal. I'd been through death. I thought, well, what are you going to talk about there? I'd become a widow when I was 34 and raising 6 kids. I didn't need any help. As she talked on through the evening, I thought, my goodness, how wonderful this is that people are looking at death as something that we can help with and that we can be supportive to the family. I had support, but not that kind of support. So I went through the training and became part of the hospice volunteer staff in June of 2000. Since then, I've seen and heard so many lovely stories about that time in a person's life. I just go on and on and on and on about it. One of the first things, and I told this story just recently, I started out at the front desk at the hospice house. It's one of those things, you think, oh, you're no big deal. You're just there and you kind of sit half the time doing needlework or whatever. But I was just sitting there, and it was a busy day. One of the nurses came by and grabbed me and said, hey, I need help in room 3. So I said, sure, I can. So I dash in and I follow her, and she said, I need some help. She says, here, I'd like to get this gentleman fixed up before they come. And I knew that just from the paperwork that he was a man that had no family or anything. And I thought, well, gee, this was nice. He was finally going to have some family come. So she showed me how to very gently go up and cradle his head, and she kind of arranged him in there, and she got the blankets all nice and everything. And I said, oh, this is great. Is some of his family coming? And she looked at me and she said, no, we're waiting for the funeral director. And I didn't realize he had already passed, so I was kind of like all of this. And then it struck me that that's what it's all about, that he was treated with such dignity. He was a man with nobody else that cared, but the hospice staff cared enough to have him looking nice for the funeral director to come. Well, then I was hooked, and I've been passionate ever since. So many stories. Another day I was at the house, and we had a lovely little Norwegian gentleman in room 1. And he was part of the Thursday morning coffee group from his hometown. And so sure enough, it was Thursday morning. I was at the front desk, and here comes all the little fellas coming in to have their coffee. So we scrounged around and got plenty of cookies, tons of coffee, extra chairs and everything. And they were there for a nice length of time. And just we could hear all the laughter, knowing that there were jokes and all the reminiscing and everything, and packed in that one little room. So they came out, and the wife came out, and she said, boy, we're really tired. She said, I think we'll both take a little nap. So they pulled the shades and shut the door and came on out, and about 10 minutes later, one of the nurses went in to check in this room. And she came back out immediately, and she said that the husband had passed in that short time. Right on her heels came the wife with tears streaming down her face, with this huge, just unbelievable smile. She just radiated, and she said, wasn't that a lovely goodbye party? That's not the end of the story, because 6 months later, she came back as a patient, and she had requested that she come back. She was hoping to get in the same room where her husband passed away. Unfortunately, it was already occupied, so we put her in one of the other rooms. After a matter of a few days, room 1 became available, and so she again requested to be moved to that room. She wanted to pass away in the same bed that her husband did, and it was only a matter of hours, and she had joined her husband from the same bed. So those are good stories. One of my first home patients was a lovely little 93-year-old English war bride. She was in a retirement home, and she was absolutely delightful. The stories that she would tell about how she came to Iowa, she didn't know what this big, huge prairie was, and when her first tornado hit, she thought it was the end of the world. She taught me how to drink English tea and pretended I liked it, but she kept giving it to me. The joy that she gave was unbelievable. Her family requested that all of us volunteers that would come would write in a little diary and kind of tell, so that when they came home after work that night, they had something to talk about. So the book was full every night for her. One day when I went, as it happened, we usually had slacks on when we were there, and for some reason that day I wore a skirt, and I walked in, and she also had a skirt on. She said, "Oh, good. Today we can dance." She says, "I always danced at home." So here she is standing up in her walker teaching me how to shimmy. So we spent a nice amount of time dancing that day. So another home patient I had was well over 90 years old. He was a widower. He lived in his rural home with a daughter and her husband. Here again, he was delightful, and we spent hours visiting. And after a few weeks, I noticed that the husband was quite often home as well and appeared to be ill. And as it turned out, he was very soon diagnosed with a terminal illness, and he also became part of the hospice program in the home. So sometimes I went for Dad, sometimes I went for the husband. One time I was there for both of them when the wife had to be gone. Unfortunately, the younger man passed away first, and it was time for the funeral, and of course Dad was in no condition to go. And the wife, without hesitation, asked if I could come and stay with the Dad during the time of the funeral. And I was so impressed that they could ask basically strangers who had become a part of their life, and they felt so comfortable having us spend that time with the Dad, because that was a very difficult time, and we shared a lot during that time when he knew that, you know, it could have been himself that had gone first, and it was a very deep and a very special time, and I was grateful that the family let me have that with them. So kick me if I run too long. One more story. Okay. After all these other experiences I see at the house, all of a sudden I became on the other end of it. In the spring of 2011, my 29-year-old granddaughter was diagnosed with breast cancer shortly after the birth of her third child. And they had lived in southern Iowa, had doctored different places, different hospitals, been in Rochester and everything, then moved up here. And then she called me, or emailed me actually one morning saying, "Grandmama, tell me how to get into hospice." So I did. I called my friends at the house, and they met her. She got really ill and ended up here at Mary Greeley in the ER before we could even make that initial consultation in her home. Transferred her immediately to the Israel Family Hospice House. We are a large family. We kind of inundated the place. But we never felt like we were in the way there. Everything was done to accommodate her, her husband, and her little children, and all the little cousins that kept running in and out. As I came one day, being on the other side, like I said, I thought being at the desk, you aren't really important or whatever. But one of my volunteer friends met me every time with this special kind of a tea that I liked. It wasn't the English tea, it was something else. But she brought that to me because she knew that would be comforting to me, and that was such a gift of love. When Melissa was in the hospital, we used every service that they had. She was in a lot of pain. It took a lot of counseling for us as family as what to do, what not to do. Her symptoms increased. She was difficult to deal with at the end, but she got nothing but compassion. We took advantage of the massage therapy, which was very wonderful. She didn't want ever to stop. And one day when some of us family members were there, the therapist invited us to watch and to learn. She taught us how to do some of the massage things, telling us that it was important to do the massage for the comfort of the patient, but it was also just that touching that was good for the patients and for us. And that connection that you don't get by just standing there saying, "What can I do for you?" It was so special, and I appreciated the fact that we did that. There were some family dynamics with that many people. You're going to get them. So we called on the chaplains, we called on the bereavement counselor, we called on the social workers. Everybody was busy for that 3 weeks time, and we really appreciated it. Within that time, the little 4-year-old was having a birthday. Her middle child was having a birthday. Melissa bound and determined she was going to go back home for this birthday party for this 4-year-old. It wasn't to be, but we had the biggest party you've ever seen. Staff brought out everything they could from the kitchen and from the family rooms. We had decorations hanging up there that we could do whatever we wanted to make the place pretty. We were inside. It was lovely outside, so we spent a good amount of time outside in the gazebo. And that mother met one of her goals by being able to give that birthday party to her child, which was so important. And then several months later, we family gathered for a small memorial back out in the gazebo, and it was a lovely time. So I'm glad to have been on both ends of the hospice, both as a giving and getting. So.
And how do you follow that? So I'm Shana, and I've been with hospice for the last 10 years. Before that, I've been with Mary Greeley for about 27. So I did labor and delivery for the 13 years prior to that. And believe it or not, it has a lot of similarities. So anyway, my part of it is the eligibility, and I am usually the one that comes to meet the patient for the first time after the doctors have decided, or the patient has decided that they don't want any more treatment, or maybe there isn't any treatment available, or the patient's failing treatment. So I am asked to make a visit, sometimes by family members, sometimes by the doctor, and sometimes by the patient themselves. So I usually have a little bit of information before I go, and usually something about their diagnosis, and the diagnosis needs to be something that's usually within the last 6 months. So if the disease progresses at its normal rate, that the patient would normally die in the next 6 months. Now, we do have patients that live longer than that, and obviously you've heard that we have patients that live much less than that. But as soon as the patient decides that, then we have some paperwork that we need to fill out. Their main doctor, their nurse practitioner, the PA, the physician, is still their attending doctor, the ones that they're in charge of their orders and things like that. You know, we contact the doctors. But then we have the two medical directors, Dr. Otteman and Dr. Carlisle. Dr. Otteman takes care of our patients with cancer or cancer diagnosis, and Dr. Otteman or Carlisle is the doctor that takes care of everybody else. So it usually works out to be about 50-50 though. So a physician needs to certify that the patient is going to die in the next 6 months, and then the medical director signs another piece of paper. And then we just start services. So it's usually, we try to make it pretty seamless here in the hospital and at home. I think we've kind of skinnied up the process here at the hospital, so we don't ask the doctors to give us orders anymore. We get those orders from Dr. Otteman and Dr. Carlisle. And then we start the services that we'll talk about in a little bit. And yeah, I was going to go back to, you know, the length of stay. You know, we've had three referrals this week, 2 referrals on Monday, and those patients have already died. So, you know, it has meant a lot to these 2 families in particular that I got to meet, and they have great stories to tell. So a lot of times what I hear, because we do follow up with these patients' family after the death, 1, 2, maybe 3 days afterwards, one of us gives them a call, and just to make sure, see how they're doing, let them know that we haven't forgotten about them, ask them about how things had gone for them and what their services are going to be, you know, provided. So I do hear a lot of great stories. You know, a lot of times they say, you know, we wish we would have had you before the end. And so those are all important things to remember. And I think that's it. Teske.
I'm going to talk a little bit about the myths of hospice care, because I think people, when you hear the word hospice, something comes to your mind. For a lot of people, it may be a building or a place. For some others, it may be their loved one who received hospice care. But there are a lot of ideas about what it is, and maybe not a lot of understanding. And so we want to talk a little bit about those myths and provide some additional information. So one of them is that hospice is about dying. And we've said this, you know, several times already, and it's in our title, that really it is about living. It's about having a good quality of life that is patient-centered, and they're making the choices, they're in the driver's seat to live their last days the way that they want to. And so we are there to really just help facilitate that. And, you know, people think that when the doctor introduces, you know, the concept of hospice to them, that means I'm going to die tomorrow. Some people have that thought, or it's a very scary kind of term for some people. I've been working in end of life for about 10 years, and over the years in various capacities, I have heard a number of times people say, well, we want to use hospice, but don't tell mom. Don't say the word. When you come in from, like you're on our services, and when you come in as a social worker, don't tell her that you're from hospice. And it's because of this misconception of what hospice really is. That wasn't dictating the care that we were providing. We were still providing good quality care from an interdisciplinary team. Also, people think that the medications, they have a fear of that. And, well, if we start giving morphine, that's going to kill them. And there is a lot of education that needs to happen, that our nurses, our doctors, they do a wonderful job of providing that to families, because they may have those fears, they may have those concerns, and that's also a benefit of us getting them on service sooner, is we have an opportunity to be able to educate and to teach them. Another kind of related thing to that is the idea about fluids, food, and nutrition, and withdrawing that, and we're not feeding grandma anymore, and these statements that really are just need to be reframed, because we know that at the end of life, as a person's body is breaking down, they're not able to process that food the way that you or I would, and their nutritional needs change, and so we're able to give lots of education about those kinds of things. Hospice is a place, as we mentioned. Many of you have seen or been to Israel Family Hospice House, and that is the hospice facility that we have at Mary Greeley. But the majority of our patients, we actually serve in their homes, so wherever that may be. It might be their house that they've lived in for 30 years. It might be a nursing facility. It might be an assisted living arrangement. It's wherever that person calls home. And some choose to come and spend their last days at a hospice house. But there are numerous programs all across the country that operate without a hospice house or a physical place to go for those last days. Kind of related to that and that concept of care, with it being that it's for the whole family. We think about the patient, obviously, as they're nearing the end of their life. What are their needs? What are their desires? But anytime you're dealing with a family system, whatever happens with one family member is going to impact the others. And so we have an interdisciplinary team that really focuses on supporting the entire family. One of the first ways that I learned about this aspect of hospice care was through personal experience. 11 years ago, I went through a program that was a perinatal hospice. I was pregnant with a child that we found out had a terminal prognosis halfway through the pregnancy, routine ultrasound, and received this news. And one of the options presented to us, which is quite rare, I think there are maybe 2 programs in Iowa, was perinatal hospice. And that is this same concept of care for the unborn child and the family. And so our child wasn't here physically, outside of the womb to have any symptom management or anything like that. But boy, I tell you, that program, it changed my life, and that's what led me to wanting to work in this field. And so don't underestimate what the hospice program can do for extended family and for friends.
And Teske talked a little bit about the team. I think we've all kind of talked about it a little bit, but it is who does provide the care in the home. So, of course, the center of this is the patient and the family, and then we are all added benefits. And I've already talked to our pharmacist. I don't know if she's here or not, but I apologize that she didn't get on this list because she's very important too. But we'll start at the top. We have our medical directors, Dr. Otteman and Dr. Carlisle. The registered nurses, there's 4 that go to the home, in the home patient's home settings, and then we have a whole group of nurses that provide 24-hour care at the hospice house. We have wonderful healthcare aides from Homeward that provide our personal cares and light housekeeping, things like that, in the patient's home. And then medical social workers, there's two of them, Amy Cornier and Yvonne Fitzgerald, who are our social workers. Amy usually sees most of the patients in the home, and Yvonne takes care of the patients in the Israel Family Hospice House. But sometimes they intermingle and they take a vacation once in a while. We have our bereavement coordinator, Teske, who is fabulous, and she's just started with us about 3 months ago, so we really appreciate her. All of the attending doctors, and I've talked to quite a few of them, are the ones that give us the referral the first time, usually. Sometimes it comes from family or a patient themselves, but it usually comes from the attending physician. And then I don't know what we would do without our volunteers. We have approximately 75 volunteers. Deanne is our volunteer coordinator, and she's the one that does the volunteer training, and they have background checks, and then she puts a volunteer where they're needed. And this isn't part of my spiel, but volunteers can do anything from taking patients their medications from the pharmacy. They can help with sitting with the patient if somebody needs to be gone. We've had volunteers that help with yard work in the yard. The patients that just not able to do that anymore. If you can think about it and need it done, a lot of times our volunteer coordinator will be able to find a volunteer that can do that. She just sends out an email, and pretty soon we have a lot of our volunteers are here today. So we really appreciate our trained volunteers. We have two chaplains, Chaplain Catherine and Chaplain Randy. He's here too, is he? We call on them a lot. We ask our patients if they want a chaplain or any spiritual care, and that's their choice. So if the patient does want that, then we call on our chaplains to come and make visits. And a lot of times that works out really well because I think there's that letting go of some things that they're not able to talk to their family about, and sometimes they're not able to talk to the staff or the team about. So it's really good. Our massage therapist, homie, that personal touch can't be, we just think that there's a huge need for that, and she sees quite a few of our patients. Some patients don't like to be touched, so that's a choice. And I tell patients when I do the admission, this is kind of a la carte. If you want, you have to have a nurse, and you need to have a social worker, but everything else is just layered on. Chaplains, massage therapy, healthcare aides, volunteers, those are all layered on your choice. And then complementary services. But also, we'll go back to the pharmacist. We have a pharmacist, Heidi. She's not here. She comes to our team meetings and helps us out with our medications. If we have any questions in the home, say a patient's taking a lot of MS cotton and morphine sulfate and several other medications, and we want to scoop them together and maybe do a fentanyl patch or an IV drip, we usually call Heidi and ask for a conversion, and then we call either the medical director or the attending doctor and say this is what our pharmacist suggests as a conversion. So this is a very much team approach, and we can't do it without the whole team.
I'll kind of expand on what Shawna was saying as far as our team. The strangest things happen that you would never think would be requests. Our dear volunteer coordinator has had some really unusual requests. One of them was that there was a patient in a group home wanted to have a live cow that he could pat, again, like a grown-up, that was the atmosphere. And somehow she managed to find a volunteer with a truck and so forth, and so the animal was taken to the parking lot, and more than just that patient enjoyed that bequest. Another one was that a gentleman was in a assisted living home, and he wanted to hear his daughter play her harp one more time. Well, the daughter was on the East Coast and could not bring her harp on the airplane back to play for her father. So many, many calls were made here again, and you know how hard it is to find a harp that somebody will loan out in the middle of Ames, Iowa, you know, like now. But they finally found the harp. They took it to the home, and the story I heard was that the daughter played for some time, the father enjoyed it, and the family was singing songs to the accompaniment of the harp as he passed away. So that was his goal, and it was very unique and very special to him and to the family. So I think that's a good example of how everybody goes out of the way. Personal experience again within the last year, my mother passed away, and she was one of those few that was there for 24 hours. We didn't know it, but the staff, it didn't make any difference to them. It wasn't just a creature laying there with no name and couldn't talk or anything. She was treated with such dignity and such care the few hours that she was there, and I was so impressed with that. That time, my sister and I were the only ones of the family left, and then since then she has also passed away as a hospice patient in a nursing home. This time, everything fell on my shoulders as far as all the legal and the things to do, and since I'm such a worrier and fixer, you know, I'm tearing my hair and trying to do all this, and our social worker takes me by the hand and says, "Hey, you can't fix it all, let me help." So she firmly and kindly stepped in, told me, this has to be done, this has to be done. But she says, I'll do this and this and this. She said, you go talk to your sister, and you become friends again like you were when you were kids. So she took care of some of these extra things. She told me how to do what had to be done at whatever time. But I got my little sister back.
Yeah, how do you follow Mary Ann? Holy moly. Whew. Especially when all of these are personal to us as they are to you. And I'm sure all of the people that are here that are hospice related feel that as well. So I just want to touch a little bit on making the choice. And we have some little nice folders. Oh, thank you, Dr. Otteman. It's the top one. So these things, we have some nice little folders that we made up for everybody that wants one. We made sure to get to the physician, so if anybody else wants them, we have plenty. And if there are not enough, give me your name, and I will get you a folder. We have all these wonderful nursing students here. How exciting is that? In the front row, because their instructor told them that they had to. So I just want to, this is a really hard decision for our patients and families. And I just met with the social workers in Joni last week, or maybe that was this week, and, you know, talking about once they make the decision, they're ready. It's very hard to get to that point, but once they make that decision, so we really try to respond quickly once that decision's made. And it's not about, it's what our title says, it's not about dying, it's about living, it's about quality of life, it's about doing activities. We try to get them to do as much as they can and as often as they can, and just really enjoy the time rather than focus on the time of what's left. So it's just be active and let us help you and support symptoms and help you to get the equipment and the things that you need. So, with that being said, Dr. Otteman, do you have anything to say before we have questions?
I can't imagine adding anything to.
Oh, I'm sure.
Excellent discussion that's been had. I think there may have only been one other time that I can remember that we had this many people, maybe never. And I think this embolizes what hospice care is about, which is it is truly the most interdisciplinary care process that I participate in, and I participate in several others. And it's organized that way. There's no one in charge. Everyone has important things to contribute. You know, one of the things that when they mention chaplaincy, which doesn't get a lot of discussion, but a couple of families I remember very well who were really struggling with a certain interpretation of what their faith required in terms of whether they could, quotes, give up or not, or whether the family could or not. And it was absolutely invaluable for our chaplains to participate in that care with those patients, because they then were viewed as much of an expert as I am, or Shawna is, or Alicia, and so on. So I want to give a little bit of extra comment to the chaplaincy staff. It has been probably the most consistently rewarding part of my practice, and I've really enjoyed and continue to enjoy what I'm doing. But hospice care is really unique.
That being said, before we do questions, I would like everybody, volunteers, staff from hospice, to kind of stand up, so everybody that's here that's not hospice knows your face and your... Thank you. Oh, there's Heidi too. Okay, questions? Come on.
I was wondering how this is funded. This is such a great service. Are we going to have to worry that either Mary Greeley will run out of money, or the insurance companies run out of money, or do we have to increase the donations? Where does the support for this program come from? Does it come from insurance? Does it come from Mary Greeley's operating expenses? Does it come from donations? Could you just give us a breakdown?
Medicare and Medicaid typically pay 100%. We get a per diem rate, so we get so many dollars per day as long as we have those patients. Once those patients pass away, we still provide care for 13 months for the family, but we don't get paid for that particular time. Insurances usually follow Medicare and Medicaid. Sometimes they have some little tweaks that might be a little bit different, but as long as Medicare and Medicaid are still around, I think we're good.
And because of that per diem, that means everything comes out of that. So medications, equipment, the nurse, the social worker, all of those things come out of that per diem rate. So some people, are down, need a lot of those things, and then other people don't, depending on the...
Another thing is the foundation here at Mary Greeley will help our patients in the billing department with financial aid. Our social workers will, talk with our patients to say, what are your financial needs, if any? And so the foundation is helpful in regards to helping us with our, our budgeting needs and our how we practice. Oh, and United Way also helps us for our home patients. Thank you, Amy.
Yeah, so my question was, you obviously do this out of payments, and my concern is about Medicaid, whether we will have Medicaid funded in the future. What percentage of the patients are Medicaid and Medicare versus insurance?
I don't know what the percentage is that have Medicaid as primary. A lot of our patients have Medicare and Medicaid. If they have Medicare as their primary insurance, Medicare pays for 100%. Some of our patients are in nursing facilities, and Medicaid pays for their room and board at that facility. And so if we have a hospice patient in a facility, then that facility bills us for the room and board. We bill Medicaid. Medicaid gives us the money, and then we pay the facility. It's kind of they just want everything to go through hospice for some reason. It gets a little complicated, but.
I'd say about 70% is Medicare based, and the rest is either the Medicaid MCOs or private insurance or those other things. The last time I looked, it was about 70, I believe.
You mentioned that your length of stay here is substantially less than the national average. Have you identified local barriers why our length of stay is much less than the national average?
Funny you ask. I just happened to read an article last night, and it had barriers to hospice care. the end of life cannot be predicted with specificity. Right, Dr. Otteman?
That is correct.
How many times have you been asked, when is my loved one going to die? How many times?
Every time.
Every time.
I
And
meet
you
a
know,
new
and what do you say?
I don't know. No crystal
We don't
ball.
have a crystal ball. And so it's hard sometimes for professionals to say, well, you have 6 months or less to live. And so that kind of, that's a mandate that we have from Medicare. You know, the patient has 6 months or less to live, you know, and who's going to determine that? Another one is the culture of medicine is that health professionals are trained to prolong life. So you know, the physicians that are here, you've been trained to, you know, help this patient to keep going, to keep living. And we're here to help them die, and that's not a common thing we talk about. And another thing is it's hard for patients and families to say, stop all treatment. You know, I've had enough. Sometimes the patient wants to stop, but the family, they say, oh no, we got to keep going. Sometimes the family wants to stop and the patient says, no, I want to keep going. You know, there's more for me to do. Dr. Otteman, you might have some other ideas about this.
Yeah, I think, David, that you know, I've thought about that for many, many years, and since I also practice as an oncologist, think about, you know, when do I get my patients enrolled in hospice care? My assessment of what goes on is that the trajectory of illnesses has changed over time. I would say that in the case of oncology patients, that our patients stay on treatment longer, and that after they have progressed, they die more quickly. So I think that trajectory has changed. I think the other thing that's influenced the length of stay for hospice is that when the program first began, it was almost exclusively on oncology patients. Now, well over half of the patients that we see have diagnoses such as dementia, congestive heart failure, end-stage renal disease, and things of that nature. As that has happened, not surprisingly, the Medicare program, even though they're willing to pay for everything, are willing to pay for fewer patients that meet criteria. It actually has become somewhat more difficult to get patients enrolled where we all could walk into the room and say, gee, would it be a surprise question? Would you be surprised if this patient died in the next 6 months? You know, you'd say, gosh, no. But Medicare and the funders for hospice have made it quite specific about how much deterioration the patient has to have. And I think that has an impact as well from that. I don't know of any way of comparing necessarily our population of patients to the national average from that standpoint.
I would like to ask about pets, how you might handle this. At home, I can't imagine that this is much of an issue, but in a facility it may be, and if somebody can answer that, I'd like to hear it.
Question. Oh, in our facility, yes. They can't spend the night. But we do have a policy. They have to provide rabies. They have to. Well, the reason was because we actually had a night nurse that went in, and the pet was in the bed, and it was dark, and they went in with the light, and it scared the pet, and it bit the staff. And so, yes, they can't spend the night, but they can come and stay all day, and as long as somebody's obviously taking care of them. But they have to provide their rabies, their injections, those types of things. But we love pets. You should see the staff. It's like a pandemonium when there's somebody. It's like a baby. So.
Oh, I'm sorry, Teske.
I don't think you're on.
Trade you.
Boy, it better be a really good comment. No pressure. No, I just want to add to that. I've done work as a social worker in hospice, and just from the psychosocial standpoint, pets are like family members to these patients, and so there have been times in my visits where I've taken a dog out to go potty because the patient's unable to do that, or that was a part of the care plan for the aides when they would go on their visits. There have been times where maybe they're not able to keep their pets, and so they're grieving the fact that they're not able to be with them anymore. So processing through that, or looking at pictures, or having a pet therapist come in, like we talked about, those complementary services, that's one of those options that we can just really individualize for people.
And I think we also have provided we've had several patients that have not had family members to take pets after they die, and we've had some hospice volunteers that have found places for those pets to go after the patients have died. So that's always kind of a nice service.
Very good. Thank you for attending, and thanks for paying attention.